Welcome to the deep dive. You've given us a really comprehensive look at renal health today. Specifically, Chapter 33, Disorders of Renal Function. Our goal here is simple. Cut through the complexity and give you a rapid but thorough grasp of kidney pathophysiology. You should walk away feeling like you really get how these vital organs can run into trouble.
Absolutely. And it's such a critical topic because, well, kidney problems are incredibly common. Your sources really hammer this home. We're talking 30 million Americans with chronic kidney disease, CKD, plus, millions dealing with kidney stones or UTIs each year. It's huge.
That scale is definitely sobering. But what struck me, and you mentioned this, is that kidney disease often isn't. It isn't the starting point, is it? It's more like a downstream effect.
Exactly. That's a key insight from the chapter.
Yeah.
So often the kidneys become sort of the secondary victim. Renal failure develops because of systemic issues that aren't under control. Think diabetes, hypertension, or autoimmune diseases like lupus, SLE. The kidneys basically take the hit from problems elsewhere in the body.
Okay, that sets up our mission perfectly then. We're going to walk through the chapter, systematically developmental issues, blockages, infections, the filter itself breaking down, and finally tumors. So let's start right at the beginning, conception and development. What can go wrong when the kidneys are first forming?
Right, the congenital stuff. The chapter outlines a few key structural issues. There's agenesis, where a kidney just doesn't form at all. Then hypoplasia, meaning it forms, but it's too small, underdeveloped. And dysplasia, where the kidney tissue itself differentiates abnormally.
And the most severe form mentioned is bilateral renal agenesis, meaning both kidneys fail to develop. The source material links this directly to amniotic fluid levels, right? Fetal urine is key.
Critically important, yeah. Without fetal kidney function, you don't produce enough urine to maintain amniotic fluid volume. That leads to severe oligohydramnios. And that lack of fluid, that cushioning, restricts fetal growth, causing a recognizable pattern of features, things like widely spaced eyes, low-set ears, a receding chin, historically called Potter syndrome. It's often life-limiting.
Wow. And the statistic that these congenital problems account for up to half of all pediatric end-stage renal disease, that's significant, a bit less severe but still structural, is the horseshoe kidney. What's going on there?
That's the most common structural variant, actually. It's where the kidneys, usually the lower poles, fuse together across the midline during development, forming a kind of U-shape. It often functions normally, but can increase risk for other issues later.
Okay, so beyond structural formation, there are inherited diseases, specifically the polycystic kidney diseases. Big distinction here between ADPKD and ARPKD. Let's start with the dominant form, ADPKD.
Right. Autosomal dominant polycystic kidney disease. This is the one you see in adults, and it's the most common inherited kidney disease, period. We're talking about the development of thousands of large fluid-filled cysts throughout both kidneys. They arise from all parts of the nephron and eventually just destroy the normal tissue.
Sounds devastating. What are the biggest clinical red flags or complications we need to watch for with ADPKD?
Two major ones stand out. First, hypertension. It often develops early because the cysts compress renal blood vessels, activating the renin-angiotensin system. And second, and this is critical, an increased risk of intracranial aneurysms, brain aneurysms. About 10% of people with ADPKD have them. It's a serious, potentially fatal complication. So it's not just a kidney problem.
That really highlights the systemic nature. Okay, contrast that with the recessive form, ARPKD.
ARPKD, autosomal recessive, is much rarer and presents in infancy or even in utero. Here, the cysts are more like microscopic dilations, primarily in the collecting ducts. But the kidneys become massively enlarged, and critically, this enlargement restricts lung development in the fetus, leading to pulmonary hypoplasia. That underdeveloped lung function is often the main cause of mortality early on.
A really tough diagnosis. Okay, so if the kidneys form okay, the next big category of problems is obstruction blocking the flow of urine.
Exactly. Obstructive uropathy. This can happen literally anywhere along the urinary tract, from the renal pelvis where urine collects in the kidney, all the way down to the urethra where it exits the body. The chapter lists common causes. You've got kidney stones, tumors pressing on the ureters, pregnancy causing compression, an enlarged prostate in men, strictures, or scarring. Lots of possibilities.
And whatever the cause, the damage mechanism seems pretty consistent.
It is. Two main destructive things happen. One, urine stasis. When urine sits still, it's a perfect breeding ground for bacteria, leading to infection, and it also makes stone formation more likely. Two, progressive dilation. The pressure builds up behind the blockage, stretching the ureter and the kidney's collecting system. This pressure eventually causes the functional kidney tissue, the parenchyma, to atrophy and die off.
So we need the terminology here. The swelling in the kidney itself is hydronephrosis.
Correct. That's the dilation of the renal pelvis and calluses. If the ureter itself is dilated, that's hydronephrosis. Now, if the obstruction is just on one side, unilateral, the other kidney can often compensate for a long time, maybe silently. But if you get a sudden complete blockage on both sides or blockage in a single kidney, if that's all someone has, that causes acute renal failure urgently.
Okay. And the most common cause of these upper tract obstructions? Kidney stones, renal calculi.
Yep, the infamous kidney stones. For a stone to actually form, the chapter emphasizes you need three things happening together. One, the urine has to be supersaturated with the components that make up the stone, like calcium or oxalate. Two, you need a nidus, a little speck or crystal for the stone material to latch onto and grow. And three, there needs to be a deficiency in the natural inhibitors normally present in urine, things like citrate or magnesium that prevent crystals from forming or sticking together.
Understanding the type of stone is key for prevention, right? Let's quickly run through the main types.
Definitely. The vast majority, maybe 75–80%, are calcium stones, usually calcium oxalate or calcium phosphate, often linked to high calcium levels in the urine, sometimes due to hyperparathyroidism or certain types of renal tubular acidosis. Then you have magnesium ammonium phosphate stones, also called struvite stones. These are unique. They only form in alkaline urine with a pH above 7.0. And crucially, they only form in the presence of urease-producing bacteria, like Proteus. These bacteria break down urea into ammonia, which raises the pH and provides the components. Struvite stones can grow very large, sometimes filling the entire renal pelvis, the classic staghorn calculus.
Wow, so seeing a staghorn stone basically tells you there's a chronic bacterial infection driving it. What else?
Uric acid stones. These form in acidic urine and are strongly associated with high uric acid levels in the blood, like in people with gout.
And finally, much rarer types like cystine stones, which are due to a genetic defect.
Okay, let's talk about the pain, because that's often how stones announce themselves. The classic renal colic.
Yeah, sounds awful.
It is. It's described as acute, excruciating, intermittent pain. It happens when a relatively small stone, say 1 to 5 millimeters, gets lodged in the ureter, and the ureter spasms trying to push it along. The pain typically starts in the flank, the costovertebral angle, and radiates down towards the groin, sometimes into the testicle or labia. Patients are often writhing, unable to find a comfortable position.
That's the colic. What about the non-colicky pain?
That's usually a duller, deeper ache felt in the flank. It's caused by stones that aren't migrating but are distending the renal calyces or pelvis, stretching the kidney capsule. It might get worse if you drink a lot of fluids quickly. And like you said, identifying the stone type afterwards is so important for prevention, maybe changing diet, adjusting urine pH, or treating an underlying condition.
Makes perfect sense. And stones and stasis lead us right into urinary tract infections, UTIs. The chapter notes most uncomplicated lower UTI cystitis are caused by good old E. coli. How does it usually get in?
The most common route by far is ascending infection bacteria from the periurethral area travel up the urethra into the bladder. Women are more susceptible due to a shorter urethra.
But the body has defenses, right? It's not like every bacterium makes it.
Absolutely. Several key defenses. The number one is probably the washout phenomenon. Simply voiding, urinating, physically flushes bacteria out of the urethra and bladder. That's why drinking fluid is often recommended. Plus, the bladder lining itself has protective properties, and in women, the normal vaginal flora, especially lactobacillus, helps keep pathogenic bacteria in check. In men, prostatic secretions have antibacterial properties.
Yet E. coli is still the main culprit, so it must have ways to overcome these defenses.
It does. Certain strains, uropathogenic E. coli, UPEC, have specific virulence factors. The most important are pili or fimbriae. These are like tiny hair-like appendages on the bacterial surface that allow them to adhere, to stick really tightly, to the cells lining the urinary tract. This prevents them from being easily washed out during urination.
Clever, in a nasty way. And anything that hinders that washout, like obstruction or urine flowing backward, that increases risk.
Hugely. Obstruction causes stasis, as we said, and reflux, the backward flow of urine, is another major factor. There's urethrovesical reflux, where urine from the urethra can get pushed back into the bladder, say during coughing or straining. More significant is vesicoritral reflux, VUR.
That's bladder back up to the kidney.
Exactly. Urine flows backwards from the bladder up the ureter, potentially reaching the renal pelvis. VUR is often due to a congenital defect in the valve mechanism where the ureter enters the bladder. It's particularly important in children with recurrent UTIs because it allows bacteria easy access to the kidneys, potentially causing pyelonephritis and long-term scarring.
Okay, let's touch on specific populations at higher risk. Pregnant women.
Yeah, pregnancy significantly increases UTI risk. Several reasons. The ureters and renal pelves dilate due to hormonal effects, progesterone relaxing smooth muscle, and pressure from the growing uterus. This leads to urine stasis. Plus, pregnant women sometimes have glucosuria, sugar in the urine, which bacteria love. The key point here is that even asymptomatic bacteria in the urine without symptoms must be screened for and treated in pregnancy because of the high risk of it progressing to pyelonephritis, which can affect both mother and baby.
Got it. And older adults, their symptoms can be tricky.
Very tricky. They often lack the classic UTI symptoms like dysuria, painful urination, or urgency. Instead, you might see nonspecific signs: sudden onset confusion, unexplained falls, loss of appetite, just general malaise. Factors increasing their risk include weaker immune systems, immobility leading to incomplete bladder emptying, conditions like benign prostatic hypoplasia, BPH in men, and crucially, increased use of urinary catheters.
Yes, catheter-associated UTIs.
They're the most common type of healthcare-associated infection, period. Catheters bypass natural defenses, provide a surface for bacteria to attach to, and often lead to the formation of biofilms. Biofilms are like communities of bacteria encased in a protective slime layer, making them really resistant to antibiotics and host defenses.
Okay, this is a huge area. Let's shift gears now to the filter itself, the glomerulus. Disorders of glomerular function. Glomerulonephritis, inflammation of the glomeruli, is a major cause of kidney failure worldwide. This seems complex, driven by the immune system attacking its own filters.
It's almost entirely immune-mediated, yes. The chapter describes two main mechanisms. Think of the glomerulus as a very specialized filter barrier. Mechanism 1. Antibodies directly target antigens that are part of the glomerulus itself, fixed glomerular antigens. The immune system directly attacks the filter structure. Mechanism 2. Antibodies bind to antigens circulating in the bloodstream, forming immune complexes. These circulating complexes then get trapped in the glomerular filter as blood flows through. The body's attempt to clear these trapped complexes causes inflammation and damage.
So either a direct attack on the filter or collateral damage from clearing trapped debris.
Pretty much. And when pathologists look at biopsies, they use terms to describe the damage pattern. Proliferative means increased numbers of cells in the glomerulus. Membranous means the basement membrane, part of the filter wall, is thickened. Sclerosis means scarring, deposition of extracellular matrix, and they describe the distribution. Diffuse, affecting all glomeruli. Focal, some but not others. Segmental, affecting only part of a glomerulus. Mesangial, affecting the supporting cells.
Okay, lots of terms. But clinically, the chapter boils down the presentation into two main syndromes, right? Nephritic versus nephrotic. Let's tackle acute nephritic syndrome first.
Right. Think of nephritic syndrome as resulting from a highly inflammatory process that damages the capillary walls of the glomerulus. It's like the inflammation punches holes in the filter.
Yeah.
So the key sign is hematuria blood in the urine, often visible, making the urine look smoky or cola-colored. Red blood cell casts are seen under the microscope. Because the filter is inflamed and clogged, the glomerular filtration rate, GFR, decreases, leading to oliguria, low urine output, fluid retention causing edema, and hypertension. The classic example is acute post-infectious glomerulonephritis, often following a strep throat infection.
So nephritic inflammation, blood hematuria, reduced GFR, hypertension, edema.
Got it.
Now the other big one, nephrotic syndrome. How is that different?
Nephrotic syndrome is fundamentally about a massive increase in glomerular permeability to proteins. The filter isn't necessarily inflamed and holy, but the pores are stretched wide open, allowing large amounts of protein, especially albumin, to leak out into the urine. The defining feature is massive proteinuria, losing more than 3.5 grams of protein per day. This leads directly to the other key features.
Because you lose so much albumin.
Exactly. You get hypoalbuminemia, low albumin in the blood. Since albumin maintains osmotic pressure, fluid shifts out of the blood vessels into the tissues, causing severe generalized edema. You also see lipiduria, fats in the urine, and hyperlipidemia, high cholesterol and triglycerides in the blood, for complex metabolic reasons. People with nephrotic syndrome are also prone to infection, losing immunoglobulins, and thrombosis, losing anticoagulant proteins.
Okay, so nephrotic, massive protein loss, proteinuria, low albumin, severe edema, high lipids. That distinction is crucial. And again, many glomerular diseases are secondary to systemic conditions. The chapter highlights diabetic glomerulosclerosis or diabetic nephropathy as the #1 cause of end-stage renal disease in the U.S.
Absolutely dominant cause. It involves widespread thickening of the glomerular basement membrane, GBM, and expansion of the mesangial matrix, eventually leading to sclerosis. The critical early warning sign, the one you screen for relentlessly in diabetics, is microalbuminuria. That's small amounts of albumin leaking out, defined as 30 to 300 milligrams per 24 hours. Catching it at this stage allows for interventions that can significantly slow progression.
We also need to mention lupus nephritis, SLE glomerulonephritis.
Right, that's a classic example of the immune complex mechanism. Circulating autoantibody-antigen complexes deposit in the glomeruli. The location of these deposits of endothelial, subepithelial, mesangial determines the pattern and severity of inflammation. It can range from mild to rapidly progressive kidney failure.
And finally, hypertensive glomerular disease, or nephrosclerosis, just the effect of high blood pressure itself.
Essentially, yes. Chronic, poorly controlled hypertension causes damage primarily to the small arteries and arterioles within the kidney. This leads to thickening and narrowing of these vessels, sclerosis, reducing blood flow to the nephrons. Over time, this ischemia causes glomerular scarring and tubular atrophy. It's a slower, more insidious process, but a major contributor to chronic kidney disease, especially in certain populations like African Americans or those with severe hypertension.
Okay, almost there. Last major section. Tubulointerstitial disorders and tumors. These affect the tubules and the spaces between them. What's the clue that function is failing here?
Since the tubules are crucial for concentrating urine and fine-tuning electrolyte balance, early signs often reflect problems with these functions. So things like polyuria, excessive urination, and nocturia, needing to urinate at night because the kidney can't produce concentrated urine effectively. Also, problems with acid-base balance.
Like renal tubular acidosis, RTA.
Exactly. RTA refers to a group of disorders where the tubules fail either to reabsorb bicarbonate properly, proximal RTA, or to secrete hydrogen ions effectively, distal RTA. This leads to a chronic metabolic acidosis, which can cause bone disease, kidney stones, and other issues.
This section also includes pyelonephritis, which we touched on, infection of the kidney.
Right, an upper UTI. Acute pyelonephritis is usually bacterial, typically ascending E. coli. It presents dramatically. High fever, chills, malaise, and that characteristic costovertebral angle tenderness, flank pain, when you gently tap over the kidney area, often needs 5E antibiotics. Chronic pyelonephritis, on the other hand, is more about progressive scarring and inflammation, often linked to recurrent infections, especially in the context of VUR or persistent obstruction. It can lead to chronic kidney disease over time.
And because kidneys filter the blood, they're vulnerable to toxins, drug-related nephropathies.
Very common. Kidneys get a huge blood flow and concentrate substances, making them susceptible. Damage can happen in a few ways. Some drugs, like NSAIDs or AC inhibitors in certain situations, can decrease renal blood flow, causing ischemic injury. Radiocontrast dye used for imaging can also do this. Other drugs can cause direct toxicity to the tubular cells or trigger an acute hypersensitivity reaction in the interstitium, certain antibiotics, for example.
Okay, last topic, kidney tumors. Let's start with kids. Wilms tumor.
Or nephroblastoma. This is the most common kidney cancer in children, usually diagnosed between ages 3 and 5. Often presents as a large, palpable abdominal mass that parents might notice. Surprisingly, it's often asymptomatic otherwise, though hypertension can occur. The good news is the treatment is very successful now, with cure rates around 90%.
That's great news. And in adults, renal cell carcinoma, RCC.
RCC is the main kidney cancer in adults, typically diagnosed in people in their 60s or 70s. It's often called the internist's tumor because it can be notoriously silent early on. The classic triad of hematuria, flank pain, and a palpable flank mass is actually uncommon and usually indicates fairly advanced disease. Many are found incidentally on imaging done for other reasons. Treatment is primarily surgical removal.
We have definitely covered a massive amount of ground here, mirroring the chapter, from how kidneys form to blocks, infections, the complex ways the filters fail, tubular issues, and finally cancer. I think that core distinction between the two big glomerular syndromes is key. Nephritic, think inflammation, blood loss, reduced GFR, hypertension. Nephrotic, think massive protein loss, low albumin, major edema, high lipids.
Absolutely. And connecting it all back, like we said at the start, look at the major drivers highlighted in your sources. So much of chronic kidney disease, especially things like diabetic nephropathy and hypertensive nephrosclerosis, isn't primarily a kidney problem. It's a systemic problem manifesting in the kidneys. Controlling diabetes, managing blood pressure, that is kidney protection for a huge number of people.
Which leads to that provocative closing thought, really. If the most common causes of kidney failure stem from these broader systemic issues, maybe diabetes, hypertension, What does that imply about how we should approach health? Does it push us towards a more integrated whole body management strategy rather than just treating organ systems like the kidney in isolation when symptoms appear?
I think it strongly suggests that. The best nephrology is often excellent primary care, managing those underlying conditions proactively before the kidneys ever take a hit. It's about prevention and systemic health.
A really powerful point to consider. Thank you so much for walking us through these sources for this deep dive.